Over here, let's just say in the heart, mom's heart, okay, there was a bacteria. Antibodies would come in and kill it, cause all kinds of inflammation to get rid of the bacteria that's in there and attack it. You'd have acute it's not myopathy, what am I thinking of? Carditis, thank you. It's not carditis, endocarditis. Let's use an endocarditis. So, why, since half this baby belongs to dad, it's no different to the body than a bacteria that's foreign. The antigens are completely negative to mom. So, we know that there has to be a force field around the uterus. Immunological force field that prevents antibodies from attacking. Now, that force field is the only thing that we have to protect that baby. If that force field is weakened, so that there's a gap in the force field, this disappears. Bad drawing, let's do it this way. There's a gap there. So now those antibodies could come in, or this lady genetically has a weak force field. Then antibodies will attack this part of the baby and create an immunological response. So, what things are going to weaken the force field, first off? Easy. Okay? Any significant systemic disease. So, I don't care which one you pull up in your textbook, okay, and you say diabetes, asthma, heart disease, renal disease, every single one of them, one of the sequela of that disease in pregnancy is a weakening of this force field, which we're going to call pregnancy-induced hypertension. Okay, so let's put that over here so you know what to call it right now, PIH. Now, what other things are going to weaken that force field? Well, number 2, which is women that are very young who don't take care of themselves. The 12s and 13-year-olds who aren't eating right, aren't sleeping right, aren't vitamin conscious, so very young. And for the same reason, she came back. The women that are older who have comorbidity. So the 40-year-olds and 50-year-olds that are getting pregnant, they probably have had some comorbidity with maybe kidney, liver, heart, and other autoimmune type connections. So the very old. Now, what other risk factors? Well, we know it's an immunological response. So, if for whatever reason this force field is weakened, and it's the first time the body sees it, it attacks it. So, the very first time, so it's prima gravidis. And interestingly enough, this is different from the other immunological diseases that you're thought of because it is human related, not bacterial related. The body sees it differently than it would a bacteria or a virus and says, wait a minute, I attacked it the first time I saw it, but I realized it's human, I shouldn't be attacking it, so I designed a mechanism to prevent it the next time. So, second time moms, okay, with the same father are not at risk, or not as significantly at risk. But guess what happens? If we already know they have a weakened force field, and they get a new baby daddy, it's a new antigen. So it's second time moms, different baby daddy, who had it with her first pregnancy. Okay? So, if you get a test question, first off, you really only need to remember 5 things. therefore what puts you at risk for preeclampsia or pregnancy-induced hypertension? It's not a big list. It's easy to remember. So, now, we say, okay, here's our risk factors. Here's the force field. So, let's just say that force field is weakened because of any of these. Or, remember the people here we're looking at have a genetic predisposition to a weakened force field. Like, for example, their mom had preeclampsia, their sisters had preeclampsia. Or, I use that term because it's easy for people to remember. Intermittently, I'm using it as the same thing as saying PIH, pregnancy-induced hypertension. Okay? But I'm going to tell you why it's a little different when we get into the fine-tuning of that. When it's weakened, what happens? We know in pregnancy, what happens to the fluid volume in early pregnancy?
Increases.
Yeah, in a singleton pregnancy, it can almost double. How does that occur? How does the body adapt for that? It uses a chemical, okay, called prostacyclin. Because prostacyclin causes vasodilatation. So capacitance vessels begin to dilate to allow you to hold more blood in your system. That's in comparison to prostaglandin, okay, which cause vasoconstriction. So in early pregnancy, there is a balance that leans this way to prostacyclin. As pregnancy progresses, this balance becomes a little more equilibrated so that it stays about even. If there's an immunological response secondary to the antigens of a baby that the body hasn't seen yet, it causes a severe elevation of prostaglandin, or, in definition, okay, a major vascular spasm. That's vascular spasm. So, what is pregnancy-induced hypertension? It's a major systemic vascular spasm. If you understand that, now we're heading down the home stretch for the easy stuff. Okay, make sense to you? Do you understand why it's occurring? Okay, anybody? Not, because this is where we have to go in order to go to the rest of the place. Got it?
I have a question.
Yeah.
What's number one?
Any significant systemic disease. Anyone, you pick one. Go look in your books and see in pregnancy what's a sequela. Always says PIH. Always says preeclampsia. I had a patient, the best example of that is I had a patient who was her fourth child. Never had PIH with any of her pregnancy. Okay? Came in pregnant with her fourth child. She was 27 weeks, 28 weeks. Got status asthmaticus. She had to go into ICU, be intubated. During that illness, she developed every sign of severe preeclampsia. Once it was done, it all abated. Preeclampsia doesn't usually go away, except for if the blockage of that force field disappears. The person that can explain that force field wins the Nobel Prize. So if you guys want to become famous, find out what causes that force field to work. So, understanding there's a major vascular spasm. Does anybody have trouble with that so far? Okay, I'm coming down the home stretch then, honestly. Because that's the basis of all this. Now you don't even need to take a note after this because you can figure it out. Like, you don't take it. I like that. You guys are good. Okay. Renal disease, renal system. Major vascular spasm to the renal system. So the blood vessels going to the renal system go into spasm. What's the first response you see? Activation of what system?
The
Renin-angiotensin system. Which causes what?
Vasoconstriction.
Increased blood pressure.
Increased blood pressure. Correct. So blood pressure is going up, right? Okay. As the kidneys become more ischemic and the glomerular mechanism starts to break down, What does the glomerulus do? What is its whole purpose in life?
Filtration.
But it holds in what?
Electrolytes.
Holds in protein.
Protein.
So that you could read, it's a osmotic gradient, correct? So that if you lose that glomerular mechanism due to ischemia, what's going to show up in your urine? Proteinuria. Remember those little pillars of the kidney? When you were in medicine, they probably talked to you about it. What happens when you get ischemia to those little pillars? There's a term for that. ATM, acute tubular necrosis. And everybody always gives me what, because I think they must have beat that into your head. Not what you see in the urine, but systemically, if you had to look for a marker for acute tubular necrosis, what elevates during acute tubular necrosis?
Uric acid.
Uric acid. Okay. You can see some blood in the urine, correct? So you get ischemic. And decreased urinary output, right? Okay. Liver. Acute ischemia to the liver. What's the first symptom people complain of? First symptom. If you've got ischemia to your liver. That's long term, as you get bilirubin raising.
Just be abdominal pain.
There you go. Pain, right upper quadrant pain. What happens? You get infarcts into the capsule of Gleason that goes around the liver. Causes severe pain. So they come in with right upper quadrant pain. 2, as hepatocytes start getting disrupted, what do you start seeing?
Elevation of the liver enzymes.
Oh, increases in AST. Okay. If it's allowed to progress further, nobody picks up on it. She lives in Egypt somewhere, and they don't see that. What could you see as long-term sequelas of liver ischemia? You have one.
Pruritus.
Okay. Jaundice. Pruritus. Okay. What else?
Like coagulopathy.
Coagulopathy. Why? Because a lot of the factors are made there. Okay. Let's go to 3. How about blood vessels? They're an organ, right? If you have a major vascular spasm, okay, blood vessels are going into spasm, what happens? What's one of the things you might see?
Platelet going down from
Why?
shearing, from being used up.
They're getting stuck in the capillaries. They're starting to stick together, adherence to the wall. So you'll see platelets dropping. What else do you see dropping based on that same system?
Red blood cells.
Red blood cells, or you see those helmet cells and all that stuff. So you start seeing a drop in red blood cells. What else do you see with spasm of blood vessels?
You see edema.
Why? I want you to think it through. Why? Take a guess.
More hydrostatic pressure, pushing fluids out.
100% correct. So you see increased edema outside of it because increased hydrostatic pressure causes an efflux of fluid out of the blood vessels, correct? So you start seeing third spacing. What else do you see? The most logical.
Blood pressure.
You're skipping right over it, right? Hypertension, increased blood pressure. Okay, let's pick another organ. Who did we forget? So let's say, oh, that was not right. Heart. Let's say this young lady is 40 years old and having her first baby, okay? And she has significant coronary artery disease. And she's going into spasm of her blood vessels. What might you see?
And you see anastomos.
Angina. Coronary, not coronary. A heart attack. Chest pain. Now, why don't we see that often? Because most of our patients are young and healthy. The heart has one of the best vascular systems until it gets attacked by all our devices as we get older. Okay, let's talk about head / neuro. Okay, what's the first symptom of brain ischemia or brain hypoxia secondary to ischemia? First sign or symptom?
Confusion.
Okay, it wouldn't be my first, but it would be there.
Loss of consciousness.
Wouldn't be my first, hopefully.
Headache.
Headache! So, I put them in like this. Headache, confusion, change in mentation, however else you want to say that. Okay, 2. What's another symptom people describe when they get brain hypoxia or ischemia?
Like vision changes?
Thank you. You had your back to me too. I was blinking my eyes back here. Gee willikers. So some people will call it scotoma. See flashing things going between their eyes and little spots in front of their eyes. What's causing that to occur in people?
The vessel spasm.
Vessel spasm, and also sometimes you can see little detachments of the retina if the blood pressure gets high enough. How's that usually present? Big fire of light that occurs. It looks like a flash of this light, and then all of a sudden they can't see well. So, scotoma, headache, 3. Going to ask you this question to help you think through the process. Everybody has deep tendon reflexes, correct? If I tapped your knees, what would you do? You do that, right? Okay, what does the central brain or the upper brain neurons do to your deep tendon reflexes? Tampers them perfectly. So if the brain is hypoxic or ischemic, what happens to your deep tendon reflexes? So you get hyperreflexia. You understand that, right? Okay, and what else does that do related to hyperreflexia? What else does the brain tampen in your peripheral extremities? Primitive reflexes. You might get clones. You might get a Babinski that you never had before. Okay? Okay. So, if it gets bad enough, what happens?
Seizures.
Seizures. / coma. Right? And then if it even gets worse than that, stroke. So far? Have you noticed that begin to look at everything you can generate if you just understand what's going on, right? None of this stuff has been difficult, correct? That's why you don't have to sit here and memorize it. If you understand the process, you know what's coming out of it. Lungs. Ischemia to the lungs, severe ischemia to the lungs causes what?
Trouble breathing.
Okay, symptom-wise, BSOB.
Hypoxia.
Okay, hypoxia. But what's the disease process of acute ischemia to the lungs? Acute respiratory distress, adult respiratory distress syndrome. Why? It's shock lung. That's all it is. The lung is ischemic. The membranes break down, fluid starts going out into the periphery, there's not a good absorptive mechanism, and until those survive and get better, chance of death is pretty high. ARDS is an 80% death rate. Does it not? Okay, what others? It doesn't usually affect adrenal glands, although I guess if it got bad enough it could. So because of the increased vascularity. So what other organs? It doesn't affect the GI system, probably because of the multiple areas of vascular connection to that system. Although I guess it could in bad circumstances. It doesn't affect the skeletal system, okay? And it doesn't affect the muscle system, and that's because there isn't a single blood supply to any of those things. It's not like one or two blood vessels are bringing that. It's a vast mechanism. So until a person, even a person who is severely septic, who has no blood pressure, you're not going to see symptoms in the muscles and the skeleton. Those just don't happen. So what organ system are we missing?
Reproductive.
Good. So, uterus, because that's all for her. She has a uterus, right? So what do you see when you get decreased blood supply due to ischemia and vasospasm to the uterus? What might you see?
Contractions.
Okay, maybe contractions, maybe not.
I was thinking, do you see like uterine atony?
Nope,
Okay.
probably not. But what did we talk about at the very first lecture?
Like uteroplacental insufficiency.
Uteroplacental insufficiency. If the uterus isn't getting it, then the placenta isn't getting it. And if the placenta isn't getting it, the baby's not getting it. So what things can you look for? Oligo. Decreased fluid. Baby's not getting anything to drink. Baby ain't peeing. Decreased growth. It's not getting the nutrients. My question for you is, someone who develops pregnancy-induced hypertension, statistically, when does that disease process start?
After 20 weeks. Or 18.
Give me a time frame, Mark. Pick something.
18.
Okay. Anybody else? I'm not saying you're wrong.
I just was reading about it, and apparently they said to diagnose it you have to wait until like 20 weeks, but the disease process has begun prior to that. Like
Process probably starts developing around 15 weeks. But when do we see the end organ problems with preeclampsia or toxemia or PIH? Not until we see end organ disease. So you don't see that usually till the third trimester. Usually it's somewhere in the 27, 28, 29, 30, 32, etc. Earlier than that, you just don't see the end organ problems. But what you might see early on is growth restriction in the baby or decreased fluid in the baby. What else might happen here? If you're getting ischemia to the uterus, which is ischemia to the placenta. Abruption. That placenta is not getting blood supply. Might just separate right off due to clots occurring in the placenta. Any other organs we're missing? How about, we didn't finish this one, I'm sorry. If I'm telling you this and this, what might else you use to help diagnose some of this in the uterus or the baby or the placenta?
Are you saying like more later in the term, like fetal heart tracing or?
Fetal heart tracing abnormalities, of course. You might have lates, decreased variability, etc. Because baby's becoming acidotic, secondary to decreased blood supply, correct? So, What I want you to look at then is we're going to look at this. Here is a graph. Over here is hypertension associated with pregnancy. And over here is seizures associated with hypertension. This we also call eclampsia, means seizures with hypertension, or the entity, this whole thing here is going to be called PIH. Okay? Now, somebody along the way said, now wait a minute. I see a patient who has elevated blood pressure, so I know there's something to do with pregnancy, elevated hypertension. And I'm seeing symptoms of vasospasm, okay? First off, in the blood vessels. So, guess what? I see hemolytic anemia, okay? And I'm seeing that happen, but I'm also seeing the platelets being chopped up. So, I have low platelets. But I'm also seeing it affect the liver. So I have elevated liver enzymes. We're just going to pinhole that out of the whole process and call it HELP syndrome. Is it PIH? Absolutely. Dave, right? I just remember the name Dave. It's easier than other names for some reason. I apologize, but it means he gets picked on more. Okay? Dave, I want you to pick 3 things. And I'm going to call this Dave's disease. Pick 3 of them and you'll be famous. You don't have to really. But I want you to understand the process. You can pick any 3 of these because not everything happens in every single patient. That's important. I tell people all the time, because you guys came out of medicine, right? That was usually what you had before you come to us. PIH is to pregnancy as lupus is to medicine. It is a systemic disease, affects every single organ in the body. How it presents itself is different, the manifestations in every single patient. But the process isn't any different. Good so far? So, now, believe it or not, you understand the disease. You know all the things that are going to occur in the disease. So where do you think we go from there? Well, what do we do about it?
Fix it.
Fix it. Okay. So we go. Sideboard.
I just have one quick question.
Huh?
I heard one of the mechanisms of that made a ton of sense. It completely makes sense. But I heard one of the mechanisms of preeclampsia is just the way like the trophoblast invades into the placenta.
We know that that may be part of the break in the system.
Mm-hmm.
Okay? Remember the force field.
Mm-hmm.
Is it possible that deeper penetration into the wall allows the body to see that mechanism? We don't know the whole thing about how that force field. There's a lot of theories about that. Studies years ago said to us you had to remove, in order to stop the process, you have to remove all the foreign antigen. So there was a study out years ago that said you should do a D&C on every preeclamptic patient after they deliver, because the disease will go away quicker if you got all the trophoblasts off the wall. Yes, that is one of the thought processes, that the invasion of the trophoblasts into the wall is how it's occurring. But then how does it occur when that person who has no PIH but develops one of those significant systemic diseases? So all of a sudden that trophoblast invaded further because she had asthma? No, it's kind of like, I use the example, compare this to migraines. We all know what a migraine is, right? What is it? It's a vasospasm, right? Of the arteries to the brain. And then there is a reflux of flow afterwards, and that's why you get a headache. What causes it?
A lot of things.
There you go. But you know what it is. That's what I want you to know. What causes it? You get the Nobel Prize. Okay? When you can figure out that force field. So I'm going to look forward to you before I retire, okay? Get that Nobel Prize. Okie dokie. Okay, see all these good people. So, let's start with the first thing. Severe preeclampsia, or severe PIH, we're going to give a different definition than mild PIH. What's going to be the difference? How do you differentiate those two?
I guess signs of end organ damage.
So, severe PIH versus mild PIH. So number one here is you have end organ disease. Absolutely. So that's the biggest, one of the biggest definitions of severe PIH. How else do you find severe PIH? It's only one other thing.
Seizures?
Nope. That's end organ disease, is it not? Everything you just showed me up here, correct, is end organ disease. So any of these manifestations, severe PIH. But there's one other thing I'm looking for. What is it?
Non-reassuring fetal status.
Is that not end organ disease?
I guess it is.
So you change your thought process. That's what I'm trying to get you to do. All of those things convert you from a person that's in mild PIH to severe PIH.
Are you asking about the blood pressure cutoff?
What is it?
I think systolic is more than or equal to 160, and diastolic is
I got you on the spot then. 110.
110.
You're good. So, 2. BP with 160 over 110, greater than. Okay? Why those numbers? Somebody just pick them out of a hat. Our studies in obstetrics told us that numbers higher than this put the patient at significant risk for stroke. So this is the stroke threshold. So, what's mild PIH? BP under 160 over 110. So, this guy is probably the only guy, okay, who is not severe preeclamptic. The person who's getting elevation in blood pressure, okay, without any systemic disease process. They also start to show early on, although you shouldn't wait for that, they start to show some proteinuria, because that's one of the earlier signs of most PIHers. Got that? So, guess who's coming to visit us now? You forgot it already?
Very sick patient.
Mrs. Smith. 18-year-old, gravida 1. And 30 weeks. Presents to labor and delivery. And she presents to labor and delivery right out from the ER. She came right, didn't even stop there, okay? And guess who you guys are the doctor. I'm the nurse and the patient. What do you want to know? Now, let me give you some hints. Okay, so what's the first thing you want to know?
Why are you here?
Why am I here? I'm here because I'm having a headache. I was doing great, sound asleep, and woke up with the worst headache I ever had in my entire life. I took some Tylenol, didn't go away. Boy, it's terrible. What was important about what I said?
Worst headache.
Number 1, worst headache. Number 2,
Didn't improve it.
didn't improve. Number 3,
Woke you up from sleep.
woke me up from sleep. Headaches don't wake you up from sleep unless it's pathologic, or at least you should be considering pathology. So, headache. What else do you want to know? Now you think, so she walks through the door, she's 30 weeks, and the first thing she says to you is, I have a headache. It's the worst I've ever had. Where should your brain go? She's pregnant. She's not in medicine, so you're not thinking, is she stroking? Is she having a migraine? Yes, that might be what you get out of it. But your brain has to be pregnancy related. Third trimester, severe headache. Is she preeclamptic? Is she PIH? That's where your brain starts to think immediately. What other things should make your brain think that immediately when she presents?
Vitals.
Well, we're going to get to vital signs. I'm talking about just history. So what other things are you going to ask me that I might say happened?
Well, she's grabbing the one. Isn't that one of the things?
Okay, so that makes you think PIH. But is there anything, so do you want to ask me other questions?
So do you have any medical history?
I'm healthy. I'm a healthy woman.
Any other associated symptoms like vision changes?
I started seeing spots over the last couple of weeks, and like these little, they look like little squigglies. I never had them before, so I'm seeing scotoma.
Any
Belly pain.
Anywhere specifically?
Up here.
You know what? Oh, you're right. God, my right upper quadrant. Oh, what the heck's that all about? I'm so left side. Right upper quadrant. So right upper quadrant pain. So what I want you to just in your brain think about is when these symptoms come up, your mind should immediately in obstetrics rule out PIH as your diagnosis before you do anything else. What next? What do you want to ask me about?
Any bleeding?
No bleeding.
The urine changes, like less urine.
You know what? I pee a lot, but I haven't been drinking as much either, but I'm not peeing as much as I used to, I think. Doesn't that happen in pregnancy normally? I'm asking you as the patient, not as the
I
doctor.
thought you pee a lot.
There you go. So decrease urination. What else?
Any contractions?
No contractions. Negative contraction. I'm saving you that part of it today.
Any chest pain or shortness of breath?
Negative chest pain, negative SOB. What else you want to ask?
Any family history of difficult deliveries?
Nope. Negative family history.
Are you following up with your OB regularly?
Routine care.
Any problems?
No.
Are you on any medications?
Nope.
Do you use any illicit drugs?
No. Gee, I'm pregnant. They don't use drugs in pregnancy. What's wrong with you? You accuse me, doctor?
Does that automatically go as a probably?
Yeah.
Uh,
Don't look at my arms. No.
Any blood in your urine when you pee?
I didn't see anything red.
any swelling of your legs?
Oh my God, you know what? I have cankles, but I've had those since ever, and my girlfriends have them, and we're all got cankles. And the husband's sitting next to you, okay? Because are cankles abnormal? Do you know what cankles are?
Yeah.
Okay, is that abnormal in pregnancy?
Seriously, do you mind describing what cankles?
It's in the calf and the ankle. Kind of like
Swelling all the distal extremity, basically. The girls call it cankles. It really isn't a name, but that's what they call it. Is it abnormal in the average pregnant woman?
Not necessarily.
No, because that's why they dropped it as a true PIH diagnosis. But I don't want you to drop it in your thought process because you know what's causing it. But it's interesting when the husband's sitting there and says, yeah, honey, you've had those cankles, but I don't know when I got married to the Pillsbury Dough girl because your face was never that swollen before. Because that's new. The edema in her face, the edema in her hands, the edema in her arms. So yes, she is very edematous. Anything else, Ryan?
Would that cause any like numbness and tingling?
It can. But pregnant women actually are very prone to carpal tunnel syndrome because of edema underneath the retinaculum that's there. one of the most common things you find as people advance in pregnancy is carpal tunnel.
I have noticed that a lot.
Anything else? So far, you've kind of asked all the symptoms, right? That we have. So what do you want to know next? You're the doctors. I'm the nurse. I'm the patient. Tell me what you want.
Vital signs.
Vital signs. I like that. Okay, so blood pressure is 180 over 120. Pulse is 110. Respirations are 18. Temperatures, I still go with the old stuff, 97.8. And there you go.
And I know we asked about drugs. Does she smoke or do you smoke?
Do I smoke? No.
Okay.
No, I don't. Okay, what else do you want?
Do you do any labs?
Well, do you want to jump to labs or do you want to do physical first?
I'll do it physical.
Want to do physical first? Okay. What do you want? What do you want me to?
How do you look like?
Pillsbury Dough Girl.
When
So
I
I'm
push,
swollen.
when I push on those cankles, is it hitting
Yes.
cankles?
So we're gonna say that I rank it out of 5, and I'd say she's a 4 out of 5 edema. 5 being like she really is the Pillsbury Dough Girl. 1 is normal, and 2 and 3 are probably normal too. So what else do you want to look at?
Eyes.
Eyes. So you look in the eyes and you don't see anything abnormal, no papilledema. So the eye exam is normal. I'm not going to write those things in. I'll just tell you that was normal.
The reflexes.
Reflexes. Okay, so you don't like your first name?
Matt.
Matt. Okay. You don't like Matt very much today. So you say, Matt, do me a favor. I want you to stand right in front of her and judge the reflexes as I hit her. So you tap him, and the next thing you know, he's a soprano. Okay? So, she's hyperreflexic. How do you judge clonus?
Thanks, Aaron. Thanks.
How do you judge clonus? What's clonus? What you do is you stretch, relax the Achilles tendon. And then, so you do it like this, and then let it go. Normally, it stops. But if she has clonus, because the brain is not suppressing that reflex, it does this, just bounces up and down. Take your finger and go right along the top of the foot, okay? You and I would clench down and try to say, what the hell's doing that? And squeeze your feet down. Babies flare the toes, okay? So you'd see that in a patient. So she's hyperreflexic. So when I do reflexes, there's 1, 2, and 3, which are really normals. 4 is hyperreflexic and 5 is clonus. So for her, she's a 4 out of 5 because she didn't have clonus. Okay, so what else do you want to do with physical exam?
Abdomen, tenderness in the like upper part.
You don't want to touch her too many times because she's got liver ischemia going on, right? You think so? You push on that right upper quadrant and it hurts. So she absolutely does have re-diagnosed right upper quadrant pain.
So you wouldn't do it on the
Yeah, you have to touch it to recreate it, but you don't go crazy with it because she's going to hurt when you press there. Just like checking for a gallbladder.
You check like the fundal height and stuff like that.
So you're going to measure the baby, and so part of that physical exam is your NST, fundal height, and possible ultrasound, which shows oligo, because you're not going to do measurements that day. So far, do you have a working diagnosis for this lady? Okay, so now you want to order labs. What do you want to order?
UA.
I'm sorry? Okay, a UA?
CBC.
Okay, well, this UA has 3+ protein. Okay? Everything else is unremarkable except for a couple red cells. 3+ protein and 1 to 2 red cells per high power field. Okay, so now you want a CBC? Can I just pick out the stuff of interest instead of doing whole CBC? White count is 15,000. RBCs, not RBC, I don't do RBCs. My brain doesn't think like that. My hemoglobin, hematocrit. This one is 16, and this one is no, I'm sorry, 48, yeah. And platelets are 72. That's enough. Does any, what's wrong with that? Low platelets. Anything else bother you?
White cells are high.
But not for pregnancy, 15,000 in pregnancy. What do you think about, look at your board. What do you think about her hemoglobin and hematocrit?
Seems high.
It does, doesn't it? Why do you think it's high?
She has more blood.
She is pushing all the fluid into her third spacing. So the question I always ask students at this point in time, let's just make the assumption, which I think is a pretty good assumption, she is a PIH patient, okay? Is this woman dry or wet? Remember, she has 4+ edema and she looks like the Pillsbury Dough girl. Is she dry or wet?
Wet.
No. She is vascularly dry as a bone. That's why her hemoglobin is 16. Okay?
She's concentrated.
She's severely concentrated. So if you restrict fluid on her because you think she's wet, you're going to cause more ischemia to the baby and more ischemia to other organs. If you give her too much fluid, you're going to cause more third spacing. But always remember that she is dry. Total systemic, oh, she's wet as anything you've ever seen. But vascularly, she's dry. No different from the patient that's in septic shock. Vascularly, they're dry. That's why you got to keep pumping fluid in them. Systemically, they're wet. Okay? So, this is one of the things I'm going to tell you. See what this is right now? After she delivers, I guarantee you it'll be 10 and 30. Because she starts reabsorbing all that fluid, re-expands her blood volume, and she's going to drop her hemoglobin and hematocrit. I have to tell you, it's a great test question for students because I'll put that on in there. Well, she's not PIH, she's not anemic. Well, first off, that's not the only sign of PIH, but secondly, that's a clue in a pregnant woman when her hemoglobin is that high that something's going on concentrating because the average pregnant woman dilutes. Average hemoglobin in a pregnant woman is probably 12 at the highest. You never see it much higher than that in the third trimester because how much cells does she reduplicate? Probably in the 100% duplicate of her blood, 30% of that cells, 70% of that's fluid. Okay? What else do you want to order?
Liver function test.
Okay. I'm going to pick the ones that I like. AST is 352. ALT is 298. LDH is 750. And alk-phos is 600. Do you have any liver dysfunction? Okay. Alk-phos. Do you think that's significant?
To mark for liver damage.
Yeah, except for it's made in the placenta. So it's not a good marker in pregnancy. That's why I threw it in there. Lactic dehydrogenase is telling you there's ischemia going on, right? So that tells you that that level's up there for that reason. Okay, what other numbers do you want to look at?
Kidney function.
Kidney function. Well, okay, you looked at urine. What do you want to know about kidney function?
Well, just like BUN and creatinine.
Okay. BUN is 20. Creatinine is 1. Is that abnormal?
I have a pregnant woman.
Thank you. It was a good answer. See, you got sucked into that because you did medicine. Okay? Pregnant women have much higher GFRs. Look at any normal pregnant woman. If you see a BUN over about 10, you better start thinking she has some type of renal disease. If you see a creatinine over about 0.5, you better check and see if she has some renal disease or she's not drinking or eating. Because normal, healthy pregnant women, GFRs are what? 180s, 200s? What's a normal GFR in a normal pregnant who's not? 130s, 150s? They're clearing this stuff. What else do you want to know? So, that's a concern because it's not abnormal, but it should start raising factors that she is dry. What else? You're on the same system, so you should look at that system.
Go for complete metabolic?
No, but we're still with the same one.
Uric acid.
There you go. That's why I keep looking over there. See, if you think of this, you know what to order here. I'm trying to get you to go back and forth. Uric acid. And her uric acid is 7.5. Greater than about 4, you start to worry. Okay, what else do you want to order on this lady? Anything else?
Here's your clotting times.
What is the clotting times?
Or like, go ahead.
PT and PTT?
Yeah.
Okay, let's just say they're normal.
Okay.
PT is 12 and PTT is 25. How's that sound? I just took that out of the text.
Yeah.
And what else do you want? Anything else you want to order? Any other tests you want to order?
Would you want an ultrasound just to check out the?
We already did that, remember?
Oh, geez. Sorry.
That's why we had oligo.
Oh yeah, there we go.
I'm forgetting the name of the item, but to check for hemolysis, is it haptoglobin or
But how's that going to help you right now?
to see if there's like a hemolysis happening?
I won't argue that it's a pump, but it's more of a medicine long-term diagnosis. An acute presentation, you really want to know what her hemoglobin is. You actually, by now, do you have any problems? Do you have any question, until proven otherwise, what this lady's diagnosis is? What's her diagnosis? Dave's disease. Okay, so the thing I wanted to get to, should you do a CT of her head?
I was thinking that.
You're a medicine again. By the time you send her down for a CT, you've waited and waited for that result to come back. It's not going to help you when she's seizing down in the x-ray department. You know the diagnosis right now. So you have to treat the diagnosis. And then once you treat it, if there's persistence in this population, then you might want to do things to prevent stroke. Or if she showed things that were more suggestive, weakness in one arm and posturing, now you might want to, well, we'll get into that in a second. You might want to prophylax her, but get her down there, and so you might need a seizure, I mean not a seizure, but a stroke protocol. But at first, you're not thinking stroke in these patients unless there's some other sign. Okay, so now you get to say to me orders. What do you want to treat in this patient? What do you want to do first?
Fluids.
Huh?
Fluids.
So you want to give fluids. What do you want to run them at?
I would at least start at maintenance IV to 1.5 times the maintenance IV fluid.
I'm a nurse. You can't tell me that.
What's her weight?
Oh, sure. She's pregnant. She weighs, and with all the edema, she weighs 200.
Goodness.
Even in medicine, way too low.
Like 100 cc's per hour would be the maintenance.
Okay,
IV.
I would probably run this lady in 150 just because she's dry. So I don't want her just maintenance. I need to give her a little bit of fluid, but I don't want to overdo it. So I'd probably run 150 cc's per hour versus maybe 125 if she was normal, because that's what you figure loss is in the average patient. Okay, so you got fluids going on board. What do you want to do next?
Magnesium.
Huh?
Magnesium.
Okay, why?
I'll let the students try that answer.
Seizure prophylaxis.
How's it work?
I'm not sure about that.
Does magnesium, does anybody in neurology use magnesium in seizure prophylaxis?
No.
So why are we using it?
Pregnancy. She is a baby.
Well, we use it because it works. And obstetricians are creatures of habit. We don't have a test population that we can say, if something works and it doesn't cause a significant problem, let's try other drugs that may work better. And we're going to use your baby, okay, as the test population on this. So that's number one. But how's magnesium work? Magnesium competes with what? Calcium. So, where does it compete with calcium? at the sodium potassium pumps in all of our excitable tissues. Muscle, nerves, okay? That's our excitable tissues. Cardiac, that's muscle, right? So, it competes at calcium for the sodium potassium channel pumps, and therefore calms all excitable muscles. So it's a great drug for decreasing neuronal activity, so preventing seizures. Why do you think in preterm babies now, they want us to give them a bolus of magnesium for 24 hours if they're going to be delivered, based on what I just told you? Let me ask you a question. I'm going to get you to think in the right direction. See your phone right there? Your mug falls over, okay, and all the coffee or drink or whatever spills into that phone. What are you going to do?
Try to dry it off.
Okay, what else are you going to do?
Remove it from the
Turn it on first.
Turn it off first. Remove it from the,
Thought of that.
remove it, take out, open everything you can, and some people will throw it into rice. Why? Because you want to get all the fluid to be pulled out of it. But why did you turn it off?
Prevent electricity from destroying it.
Preventing hyper-stimulated signals from going in pathways that they're not used to going in, or creating new pathways. So, babies with young brains that are going to be delivered and get hyperstimulated, we can decrease neural complications by shutting the brain down in the very beginning, by decreasing neuronal excitativity. Easy for you to say. What else does, if magnesium takes all muscle or all excitable tissue and prevents it from being as excitable, okay, what other tissues does it affect?
brain.
We already said brain,
Like the diaphragm. Yeah,
Yes.
there you go.
because the diaphragm is a muscle, correct? So one of the long-term problems of too much magnesium is paralysis of the diaphragm. So, if I know that, right? So I know if I give her too much mag, she's going to stop breathing on me, right? Because the diaphragm's going to be paralyzed. So how do I prevent that? Do mag levels, right? So we're going to do a mag level every 10 minutes?
Mm-hmm.
6
2
hours?
4 hours.
4 to 6 hours.
See, you guys are not thinking out of the box now, okay? You should ask me the next question. Is there anything else that I can test in mom that would disappear before the diaphragm stops moving?
Neuroreflexes.
Exactly. If peripheral muscle goes out before the diaphragm because it has a much better vascular supply to the diaphragm, so it's going to clean out the magnesium quicker. So that's why your nurse goes in every hour and taps the knee. If there's no reflexes, she knows, mag's getting too high. If it keeps going up, she's going to stop breathing. So she sees no reflexes, she does a mag level and turns the mag down. That's the reason they're tapping knees, is because she knows the leg will go out before the diaphragm. But what other tissue responds to magnesium?
Uterus.
Uterus, and we've used that for years to decrease uterine activity or contractions. But that's not something we're worried about right now, correct? I mean, because the uterus wasn't contracting. You asked me that early on.
Heart.
Heart, but we really don't necessarily want mom to slow her heart down too much, right? What other tissue?
Brain?
We already did brain.
Smooth muscle.
What caused the vasospasm? Constriction of muscle. So, it helps dilate blood vessels, so it helps bring down blood pressure a little bit as well. It's not a major component to it, but it is a component. So, we're going to give her mag, and usually what we do is 4 grams bolus, and then 2 grams per hour. What are you going to do next? Remember, you look at this, and begin to think as an obstetrician.
Blood pressure control.
Okay, What is your goal of blood pressure control? You want to know what her pre-op, early pregnancy blood pressure was?
Sure.
Okay. Her early blood pressure was 110/62.
At least around 120/80.
Did you just pick that out of the air?
So normal blood pressure.
Reduce it
range,
below 160
but
to 110.
I'm sorry?
Reduce it below 160 over 110, but not fast.
So you want to, so you're gonna give me, you're gonna tell me, I'm the nurse, tell me what are my parameters, where do you want it? Think your thought processes, you got it. You actually were better, you had it right on target, you just gotta think that through. Give me parameters, I'm the nurse.
I want a target of 150 over 100
Okay, and why did you pick those numbers?
because it's right below the seizure threshold. It's
Okay,
just-
so that part I like. Why don't you like her numbers? It's below the Caesar precautions.
Because I bring her down that quickly would probably do more harm than good.
Why?
Um,
This is the thing. Think it through. You're doing great.
well, it would cause harm to the baby because it would cause uterine insufficiency.
So what happens is if you decrease the blood pressure too quickly and too much, you're going to get hypoperfusion and end organ disease, and you're going to make the disease worse. So you were right on target. I just wanted you to think through the process, and you did it. Good. The process says get the blood pressure below the seizure precautions that we're worried about, but let's not hypoperfuse. So in medicine and obstetrics, we usually use 3 drugs as the first line. The first line for years has been hydralazine. I'm putting it in there as a first line because I think it's easier to start there. It's not our first line anymore. What is hydralazine? Anybody know?
Arterial dilator.
It's an alpha blocker, okay, which causes arterial dilation. So, it drops blood pressure, correct? What's the side effect of hydralazine? Biggest side effect?
Syncope.
Oh, any dropping of blood pressure might cause syncope.
Is it a rebound hypertension?
Not hypertension.
Or
If your blood pressure, if your blood vessels start to dilate, which starts dropping your blood pressure, how are you gonna bring that blood pressure back up?
Thank you.
You're gonna get tachycardic.
that's right, reflex tank.
Reflex tachycardia. So the biggest problem with hydralazine is reflexive tachycardia. So to do that, they came up with labetalol. And what is labetalol?
Non-selective beta.
It is a mixed beta and alpha blocker. It has beta and alpha, and therefore it causes peripheral vasodilatation, but it also slows the heart and prevents reflexive tachycardia. So it has become the first line drug. And then 3, nifedipine. What's nifedipine?
Calcium channel.
Calcium channel blocker. Sounds familiar. Who else was it? Basically a calcium channel blocker. Mag sulfate, a different type. Okay? But it's more selective to blood vessels and cardiac tissue. So, nifedipine is a good drug to cause peripheral vasodilatation and also help prevent reflexive tachycardia. What's its limitation? The reason it's not first line for us.
Doesn't it cause edema?
Stops working after 24 hours.
No. It's its way you get it. It's oral. It's harder to dose it. You can't dose it IV. You put it under the tongue. I know, she doesn't understand that I'm lecturing. It's one of the people trying to tell me that something for my office. And it's not important, but... Okay, so the reason is that you have to do it sublingually or orally. There isn't an IV dose for that. So, you're getting blood pressure below 160 over 110, right? So right on target. 1, 2, 3, 4. What else are you gonna do for this patient? Read, look at your whole process here, and look at your diseases here, and think of the whole patient now.
Does she need pain control?
Thank you. So you're gonna give her something for that pain, right? Because it's not gonna go away instantly. But you don't wanna do it long term because you wanna see either she's improving, just give her something. What else you wanna give her?
30 weeks, so
Oxygen?
Okay, so you can give her some oxygen. But that wasn't what I was thinking, but.
Maybe you have like steroids or something?
Steroids, why steroids?
Mature fetal lung.
Why do you want to mature her lungs?
Preparation for possible delivery before 34 weeks.
Does preeclampsia without something up here, does it get better without doing anything? No. How do you make preeclampsia better?
Deliver the baby.
Get rid of the antigen that's causing it. Correct. So, the question is, at this patient, you have to think in your mind, does she meet the criteria as a severe preeclamptic? Okay. So, you know that you're going to have to deliver this baby at some point in time, and it probably isn't going to make it to term. So now the question is, when? When do I deliver this baby? Unless there's something else you want to treat. Anything else we need to change? I think you treated everything. You've done pretty good so far. So when do you want to deliver this baby? And how?
C-section.
if the mom doesn't respond to our treatment.
Okay, first thing we're going to do is look at the balance of mom and baby over here, okay, and length of pregnancy over here. You want the length of pregnancy to be as long as it can, but as soon as mom or baby start getting sicker, then length of pregnancy doesn't become an issue anymore. So the first thing we're going to do is say, okay, is mom or baby significantly getting worse right now or in trouble? So let's just say, we already said the non-stress test was reactive. Mom's blood pressure gets down to 140/80, okay? And she's not having as much chest pain as she did before, or right upper quadrant pain. Headache's a little better, but you're giving her some medicine for that, and she's on plenty of medication to help this. But you know we have end organ disease, correct? We have liver, kidney, brain, vascular. So this lady's got some real issues. Now, when do you want to deliver her? Everything is kind of, you know, she's still got PIH. She's still severe PIH. When do you want to deliver her?
And the baby's doing fine.
Right now, baby's doing fine.
I would say she's probably unstable, so you should try to get it out like as quick as you can.
So you want to do it now?
Yeah.
Okay.
Or as long as, I guess, like if you just gave the steroids, I don't know how long you actually have to wait after.
Anybody?
I was gonna say just wait for this. How long?
How long do you want to wait for steroids? 24 hours after the second dose is your maximum time. So you can give them 12 hours apart in an urgency. So basically, you'd like to buy 36 hours for this patient if you can. Okay? After 36 hours, really no major benefit for severe preeclampsia to go any further. Okay? Because you're not going to save her. She's only going to get worse on you. Now, how do you deliver her? You want to do a C-section? Why?
She's still 30 weeks. She has severe preeclampsia and her
She going to heal better by C-section? Is baby going to do better by C-section? Isn't that really the two criteria? Is mom going to do better, or is baby going to do better by C-section?
wouldn't you be expecting more complications
Why?
trying to do a vaginal delivery just given the other risk factors?
What risk factors for vaginal delivery?
And
So a preterm baby's better by C-section? than by vaginal delivery? I'm throwing these at you. I want you to think through them. I'm not asking you to be an obstetrician. The truth is that a vaginal delivery is more beneficial unless the baby's in the wrong position. So you wouldn't want to deliver a premature breech unless you had to, okay? But if they are vertex, mom's going to do better and there's benefits for baby. The dilemma comes to is, do you think you can get the baby or mom, or you think you can get this baby out and mom delivered before mom or baby gets in trouble? At 30 weeks, there's a high probability that her cervix is thick and closed. So there are certain doctors here, and I'm not going to say names because I don't want to put people into that position, that don't want to wait that at all. And will just say, her cervix isn't ready, let's just do a C-section. We also know that, what did I tell you, is she dry or wet? Okay, so if you give a milligram of Pitocin to her, or a milligram of Pitocin to a non-preeclamptic, is it the same amount? No, it's a lot more concentrated in the PIH. So they tend to actually respond to Pitocin quicker, and you can still give them prostaglandin. So you may be able to get this patient out below and not have to put her through a C-section, which is a harder recovery. What I'm trying to get you to think is that you need to get mom delivered and get baby out at some point in time. What you have to decide is what's going to be best for mom and baby. C-section isn't necessarily the way you have to deliver these babies. Some people will choose to do that. And that usually is due to the fact that they don't want to stay around and watch it. Or mom is getting sicker or baby's getting sicker. Guess what, guys? You got it. That's why I wanted you to go through this, through the process. Because really, you understand it now. You know how to treat it. Watch what happens in the patient you saw the other day. It's all the same. It just is really what symptom presents. Once you've made the diagnosis, then you treat the things that needed to be treated and deliver them when baby and mom are going to do best. Okay? Have a nice New Year's. I hope this helped you.
Yeah.
Good. Okay. Good job. You guys saved